So we're going to talk about abnormal liver test, and how I like to think about this is just when you first get a set of liver tests, how are you going to start categorizing what you're going to do, what you're going to order, what you're going to tell the patient in your mind, and that's best by dividing the test up into what they're useful for. And so I always found this scheme to be the most useful for me. Dividing it into the inflammatory tests. These are your transaminases, AST and ALT. If these are elevated, they indicate that there's been injury to the liver, some inflammation. This is not functioning of the liver at all, and so they really shouldn't be called liver function test. They're only telling you about injury. And I do want to mention in the syllabus, I think they got the halfway done version of my talk instead of the final version. That was my fault for sending in the incomplete version. So some of these slides will be blank towards the end because I hadn't done them yet when I made that talk. But I'll hit all the high points and you guys can jot it in if you want to. Back to the slide, the next category is cholestasis, and the only useful test for that in the standard LFT panel is the ALK-Phos. And bilirubin is often thought of as a cholestatic test, but it's not really useful as a cholestatic test because you can also see that in inflammatory injuries. And so, of course, if you have an obstruction, bilirubin will go up, and we'll talk about that more in detail. But the one test that you want to look for cholestasis is ALK-Phos. And then what are your actual liver functioning tests? These are your synthetic tests. These are what the liver actually makes. And the most useful one by far is your INR because it's your measure of your clotting factors. But you can also look at albumin and bilirubin. And then finally, the non-liver tests that are actually liver tests, platelets and creatinine, because they're also very useful in assessing your patient, especially in cirrhotics, and how sick they are and if there's portal hypertension. So we'll go through each one of these individually. So your transaminases, AST and ALT, these are from the liver cell. The AST is from the mitochondria, the ALT is in the cytoplasm, and looking at the AST-ALT ratio can actually give you a lot of information. So a normal AST-ALT ratio, the ALT should be higher than the AST. And in most patterns of liver injury, your ALT is going to be higher than the AST. And we all know the classic example where this is not true, which is alcohol. Everybody remembers that 2-to-1 ratio AST-ALT. So that's kind of your one classic example where the AST will be higher than the ALT, and that's because alcohol damages the mitochondria more, and that's why you have a higher AST release compared to ALT. And then the other useful switch is when the AST becomes higher than the ALT is a strong indication that patient is cirrhotic. And so they're getting liver damage, say they have hep C or they have fatty liver, and they don't have cirrhosis yet. The ALT will be higher than the ALT. But once they make that switch and they actually develop enough fibrosis to go over to cirrhosis, the AST will now be higher than the ALT. This doesn't always work, but it's probably true about 80% of the time. And so without doing anything else, you can kind of already have a hint that this patient has chronic hep C, the AST is higher than ALT, they probably have cirrhosis already. And then you combine that with some other factors like the platelets to kind of make that decision. AST is less specific to the liver than ALT. Many years ago, AST was even part of the cardiac panel to decide if someone was having an ischemic injury to the heart during a heart attack. And so that, of course, troponins have replaced all that. But AST is released from all kinds of things. So if you see a really high AST and that ALT is normal, you should be thinking that this is not a liver injury. This is coming from somewhere else. Rhabdomyolysis is kind of the example I get in the hospital a lot. Someone's found down and their AST is very high. All the other liver tests are normal. It's probably rhabdo. It's not a liver injury. But it can also be released from the intestines. We'll often get consulted for someone who has like acute gastroenteritis type symptoms. They're throwing up, they have diarrhea. Well, their bowel's inflamed, and so the AST is going to leak and be a little high. So AST is not as specific as ALT. If ALT is up, you definitely want to think this is probably coming from the liver. But other things can also cause elevation. So celiac disease is another classic example related to the bowel. So if you have a patient that's at risk for celiac, they're younger, they're usually Caucasian, and they have this mildly elevated AST-ALT, you want to think, could this be celiac disease? And so that's part of my usual workup when I get someone in the office is I'll check for celiac. Thyroid disease, having chronic heart failure can also raise AST-ALT, and then Addison's and anorexia. So there are other things to think about other than primary liver disease. And this is kind of a summary of that thought process. The ALT is higher than the AST in a normal patient, usually less than 30. And I'll stop here too, is what is a normal AST and ALT? And if you look at the labs, depending on where they're from, I mean, it's all over the place. I mean, Quest, LabCorp, the hospital, you know, they'll consider their upper limit of normal. Sometimes it's 50, sometimes it's 65. It's just kind of crazy. And why is that? It's because they take, you know, their distribution of patients and they just picked 2 standard deviations above the mean, and that's became their upper limit of normal for that lab. And so, and if you have a obese population, and a lot of people have fatty liver disease, they're not diagnosed with having a liver disease. They're included in this normal liver patient population, and it's not normal. I mean, so most of these people are not normal. So what is a normal ALT? In women, the you know, GI societies say it should be around 19 or 20, which, you know, that's really low. That's a normal ALT is 20. In a man, it's around 30. So that's what I use as my upper limit of normal, you know, for AST and ALT. And you know, you got to kind of take, so if you get a lab back that says 54 and that's normal on that lab, that's not normal. You have to think that that's high for a reason and maybe you should investigate. And then going down to acute liver injury, ALT is again higher than AST. And if it's an acute injury, you're thinking, is this viral? Is this a toxin or some kind of medication overdose? Is this ischemia? And this is when you see the labs above 1,000. Those are the 3 things you should think of: ischemia, some kind of drug or medication or exposure to something like an herbal, and acute viral hepatitis if your AST, ALT is over 1,000. Chronic liver disease is usually under 300. This is like your chronic hep C, your chronic hep B, your hemochromatosis. Those are things that are going to cause AST and ALT to be usually less than 200, but definitely under 300. Alcoholic hepatitis, again, we mentioned that 2-to-1 ratio. Everybody remembers that. And then cirrhosis, that AST is now higher than the ALT. But again, the labs are usually lower unless there's an acute injury going on in addition to the cirrhosis. So your AST and ALT are not going to be higher than 150. And then the acute injury in alcoholic. So if they're an alcoholic and then they overdose on Tylenol, then you can see the AST higher. So alcohol kind of throws everything off in that scenario. So if they have a history of high alcohol use, even though you're like thinking this is a acute Tylenol toxicity, the AST can be higher than the ALT in that scenario. So if there's history of alcohol abuse, that's going to increase the chance that the AST is going to be higher than the ALT. So moving on to cholestasis. The alk-phos is actually part of the liver cell. It's not actually released from the bile ducts, but it's at the apical membrane that releases the bile into the bile duct. And so when there is pressure in the bile ducts, you get release of alk-phos, and so that's why it's a useful a test for measuring or looking at cholestasis. But you have to remember alk-phos is from other sources also. And so the big one, of course, is pregnancy. A pregnant woman, the alk-phos always rises, and that's normal. But bone and kidney injury can also have an elevated alk-phos. And so we'll often get a consult for an isolated elevated alk-phos. What do you do and how do you work that up? One other thing I'll mention is certain tumors like ovarian cancer and lung cancer can have an elevated alk-phos. And so that should be, in addition to liver disease, in the back of your mind, is this patient a smoker? Could they have a lung cancer? So here's that isolated elevated alk-phos. All the other liver tests are normal. Alk-phos is elevated. How do you decide, is this liver or is this coming from somewhere else? The most useful test is a GGT. If you haven't done that, check that. If that's elevated, it's probably coming from the liver. If it's not elevated, you need to look elsewhere. All those other things I mentioned, tumors, is the person pregnant? Is it coming from their bones? Do they have prostate cancer that metastasizes to the bones? Those are all things to look for. People ask about the other tests, like the 5-nucleosidase. It's helpful. I usually just get the GGT, and that answers the question for me, so I don't often order it. And then the fractionated alk-phos. I really don't find this one helpful at all because the pattern always comes back as 25% liver 1, 25% liver 2, 10% bone, and then the rest intestine. And it's always kind of a variation on that theme, and I don't know what to do with that. It just doesn't help me at all. Unless it comes back all bone or all intestine, then it might be helpful, but I've never seen one like that. So I just use the GGT as my kind of primary way to start the differential. And then you want to split it into, is this obstruction of a big bile duct or is this intrinsic to the liver? And so how can you tell that? Is either one's going to have elevated alk-phos, but then you take a look at the bilirubin. If the bilirubin is also elevated, that is indication. It could be either one, but if it's high, you're thinking of a big duct blockage. Because unless you have all your little ducts blocked, the bilirubin shouldn't be elevated that high. And so you're thinking, what can block the common bile duct? Cancer, a stone, a stricture. Those are what you're looking for. And how do you figure out if it's one of those? Imaging. So you get your MRCP, you get your endoscopic ultrasound, and you get better pictures of the bile ducts and decide, is there anything blocking that? If the bilirubin is not as high or fairly normal and your imaging is normal, then you're thinking, could this be some kind of intrinsic disease? Sometimes you end up getting a biopsy, and if you see proliferation of bile ducts, and this is not something that primary care docs are going to be interpreting, but that's a hint that it's obstructive jaundice. And your bile ducts actually don't proliferate. It's actually, they just get longer, and because they're all squiggly and moving around, when they do the biopsy, you see more bile ducts on the biopsy sample. It's not that because there's more of them, they're just a lot longer, and they went through the field of biopsy squiggly over and over again, and because they elongate because of the pressure from the blockage. And so when you're thinking obstruction, those are kind of your big diagnoses. We already mentioned these. Bile duct obstruction of some kind, stones, strictures, malignancy. Liver transplant patients can have this done, and that's often an anastomotic problem where they sew the bile ducts together. And then PSC and PBC, they can make either pattern, either look like obstructive or intrinsic. And here's the intrahepatic or intrinsic problems. And these are the ones that are kind of, people don't think of immediately or are easier to miss. And so drug-induced liver injury, alcohol, the elevated liver enzymes of sepsis. So you have a patient that's real sick in the hospital, they have pneumonia or urosepsis or something infectious is going on. You can get elevated alk phos, elevated bilirubin, and that's because of that inflammatory cascade and the cytokines affecting the liver and not allowing bile synthesis and release into the bile ducts well. And then the ones that are often missed, and these are the hard ones to find, are the infiltrative disorders: sarcoid, amyloid, TB, fungal infections, and cancer. And so, big, cannonball lesions in the liver, those are going to be seen on imaging. But some cancers don't, produce these cannonball lesions, and you get more of an infiltrative pattern. Lymphoma is the big one that does that often. Small cell lung cancer is the other one. And so, if you have an elevated alk phos and total bilirubin is a little high, and you do a CAT scan and there's nothing there, that's when liver biopsy can be very helpful in figuring out, because when you biopsy, you'll see the malignancy that's hiding there in plain sight. And then, of course, PSC and PBC can also have this pattern. And then finally, when you have AST, ALT, and alk phos all elevated, again, PSC and PBC can all do that. Biliary obstruction, I've seen many patients with choledocholitis, a common doc stone, with really high AST, ALT, alk phos, and total bilirubin. Any drug-induced liver injury, even though that's mainly a cholestatic pattern, can also raise all three at the same time: AST, ALT, alk phos. And then your autoimmune diseases like autoimmune hepatitis and any of the overlap autoimmune diseases can all have a mixed pattern where everything's elevated. And those are, again, these are not going to be your final test, but it kind of gets you down the right pathway to start looking for these things. Moving on to liver synthesis. These are your clotting factors. INR is the way that we measure this easily and readily available. And if it's elevated, you want to be thinking that the liver is not functioning properly, and that's why it's included in the MELD score and in the child's Pew classification, because it's as a direct measure of how the liver is producing what it's supposed to do. And so it's one of the only true liver function tests. I also included on this side, there's a common misconception that all cirrhotics are easy bleeders. This is not true. Just because their INR is elevated does not make them an easy bleeder, because the liver makes both clotting factors and anti-clotting factors. And we only can measure easily the elevated INR, which would indicate that they would be an easy bleeder. But in this little chart I put at the bottom here, as you can see, if you have less clotting factors and a lot less anti-clotting factors, you're actually hypercoagulable. So that's why you see these cirrhotics that come in with the portal vein thrombosis or the mesenteric vein thrombosis. So just because they're cirrhotic and they have an elevated INR does not mean that they're an easy bleeder. It could be either one. They could be totally even, they could be hyper or hypocoagulable. And so just because a cirrhotic is bleeding doesn't mean more clotting factors is going to solve that problem. That's why we don't really give FFP or platelets often in these acutely bleeding patients. We're going to put them on octreotide and do an endoscopy to stop the actual bleeding, because we don't know if it's a clotting problem or not, and you don't want to waste time waiting on your FFP to kick in. That's not how we treat that anymore. Any questions about that? Because I always get that question: is why does this person have a thrombosis of the portal vein? And that's the reason, is because we can't measure the anti-clotting factors, even though they have an INR of 3. Moving on to liver synthesis, looking at bilirubin, the big test, and this is what you'll get from an actual LFT panel versus your CMP. In the CMP, they don't include a direct bilirubin, so you have to often go and order that separate test. But if you order just an LFT panel and break up your CMP into a BMP and an LFT, you'll get the direct bilirubin automatically, and that will help you decide, is this a conjugated hyperbilirubinemia or an unconjugated or direct and indirect bilirubinemia. And where it's helpful is one of the most common reasons to have an elevated bilirubin is Gilbert's disease, which is an indirect hyperbilirubinemia. It's a genetic disorder. It's autosomal dominant. It's very common, about 10% of the population. So if you see kind of an isolated, elevated total bilirubin and you fractionate it out and it's mostly indirect, they don't have anything wrong with them. They just have Gilbert's disease. You don't need to do any further workup. The other genetic disorders, we're rarely going to see and diagnose as an adult. It's more important in the pediatric population, like things like Dubin-Johnson syndrome, Roeder's disease, and Crigler-Najjar. That's not something that they usually make it to adulthood without being diagnosed by that time. That's that. And then here's more on Gilbert's disease. Again, this is the classic example is that they come in, their bilirubin's like 4, and you break it up into direct and indirect, and their indirect is 3, their direct is 1, and you find out they were fasting that morning because they were getting their labs done, or they had an acute illness, and that's why they had their labs checked. That's when you often see this bump in their bilirubin. If you recheck it again a couple weeks later when they're not fasting and they're feeling better, the bilirubin's often back down to normal or close to normal. And if it's kind of consistently that indirect pattern, you don't need to do any further workup. It's just Gilbert's disease. And then the non-liver test, platelets. These are very, very helpful. If it's less than 125, the platelet count, they're almost guaranteed to have cirrhosis unless they have some kind of platelet disorder. So in your general population, if you do a CBC and the platelets come back as 110, you should immediately think this patient has cirrhosis until proven otherwise. It's the most sensitive lab test we have for portal hypertension. And when you look at all of our little calculator assistants, like there's different scores, the FIB4 and the fatty liver disease score that you can pop in these different labs, they all include platelet count because that's the most sensitive marker for portal hypertension. So again, if you see a platelet count under 125, you think this patient has cirrhosis, unless I can say they have TTP or they were on some drug that would lower their platelet count. You shouldn't send them to a hematologist first. You should send them to one of us to see if they have cirrhosis or not, especially with fatty liver being so common nowadays and leading to a lot of undiagnosed cirrhosis. Creatinine is also important, and that's mainly for people that have known chronic liver disease and they have cirrhosis. It's the best predictor of 30-day mortality. If that creatinine is climbing and you don't know why, like you haven't increased their Lasix or Dactone, you haven't adjusted their medications, they're in big trouble. They need to be seen, evaluated. Are they on a transplant list? You need to get the transplant center involved, because if that creatinine is going up, they could have hepatorenal syndrome, or they could just be decompensating quickly, and they may need help quickly. So keep an eye on that creatinine. That's why it's part of the MELD score. And here I mentioned both of those scores that we use. The Child-Pugh score, it was initially developed for surgical risk stratification, and it kind of divides patients into Child's A, Child's B, or Child's C. So you have 3 kind of stages, A being the best stage, you're doing good. That means you're compensated. That means your surgical risk is about average compared to an average person. So these are the people that if they need to get their gallbladder out and they have cirrhosis, they're probably going to do okay with that surgery. If they're a B or a C, you certainly don't want to operate on unless it's a life or death emergency. Those are the patients that are going to decompensate quickly after an elective surgery. You don't want to let them have surgery. B is kind of the borderline, and you really want to make sure that this is the right thing to do in this patient before you send them to surgery. And that's why that score was developed. But also gives us a good idea kind of overall how the patient is doing. And it includes 5 factors, and you just kind of plug them into one of these calculators. Albumin, total bilirubin, INR, whether or not they have the presence of ascites, and whether or not they have hepatic encephalopathy. And it gives you a good idea how overall that patient's doing. But the downside of the Child-Pugh score is it's somewhat subjective. Grading ascites is the grade is either they get 1 point for a little bit and 2 points for a lot. And who decides what's a little and what's a lot? And same thing with the hepatic encephalopathy. They're a little confused, or they're completely confused, and whether or not they need medicines to control it. And so it is somewhat variable based on who's doing the score. The MELD score took away that, and it's all just numbers, so there's no debate about what it is. And the MELD score was updated in 2016. But prior to that, it only included 3 numbers: the INR, the creatinine, and the bilirubin. Now it includes the sodium in addition, so there's now 4 factors that go into the MELD score. And this is what transplant centers use to decide who gets a transplant so that it's fair, or more fair. because there's no subjectivity to it. Those are just numbers, you check them, and then they go into a formula, and it spouts off a score. And so every time I see a cirrhotic, I calculate both of these and put it in my note, and just so I can go back through time and see, you know, what were you 6 months ago, what were you 2 years ago, and which direction you're heading. Now, there are ways that these numbers can be wildly different. You know, say you put them on too much Lasix because their ascites is worsening and their creatinine goes up. The MELD score is very sensitive to their creatinine, and so their MELD score is going to look terrible. And then if you just adjust their medicines again, it'll come back down, and so the patient isn't truly as sick as their MELD score kind of indicated. And sometimes, you know, transplant centers have been known to, if they really want to get a patient transplanted, they, you know, adjust their diuretics to make that happen. So their creatinine will climb and their number will climb. But you didn't hear that from me. But they do use this score to decide who gets a transplant. And in Florida, it's around 23, 24, 25 is the MELD score you have to hit before you're going to be high enough on the list to actually get the transplant. And so when do I send patients to the transplant center is when they hit 15. So if their MELD score is under 15, I'm not going to even waste the transplant center's time. They're not sick enough yet. But if they hit 15, they're getting, you know, they're getting worse. I'm going to refer them to whatever transplant center if they're interested and they qualify. They're not drinking. They're not too old to at least start that process, because it's about a 6-month process to get, you know, even on the list. There's so many, you know, tests, and cardiologist has to see them, the psychologist has to see them, and so you want to start that process early so they can get the transplant in time if they go down quickly. And then last, drug-induced liver injury. This is something I get a lot of consults for. You know, is this medication causing an irritation of the liver or causing the AST-ALT elevation? And so the first question is can this drug be causing it? And the answer is always yes. Any drug can cause drug-induced liver injury. There's, you know, the drugs that we commonly think about, but then there's anyone can have an idiosyncratic reaction to any drug. And so, for example, I have a patient that was sent to me, you know, from primary care in Georgia after getting Augmentin. And Augmentin is something we all use every day for all kinds of things. And she had a terrible liver injury from it. You know, AST, ALT in the thousands. Bilirubin went up to like 18, and she was extremely jaundiced. And this poor lady did fine. He recognized the problem. He stopped the drug, but she was so angry with this doctor for using such a bad drug on her. And I had to explain to her. I mean, he was no way he could predict that this was going to happen in you. You should never be on Augmentin again. But this was just an idiosyncratic reaction, and it's not his fault. It was just random chance, and so they should never be on that drug again. But when do you know if it's safe or not? I mean, that's clearly a drug you want to stop. If they get jaundiced, you want to stop the drug. But when is it safe to kind of see what happens? And the magic number is less than 3 times the upper limit of normal. And so I've kind of illustrated that in these graphs here. The bottom graph, the blue one, or has 2 little spikes. This is like a normal person. If you just check someone's LFTs every month or every 2 weeks and charted it, you're going to have blips in everybody that are going to go up a little bit and come back down, up a little bit and come back down. So that's normal. So a normal person can have an elevated AST and it means nothing. So the next patient comes in and you put them on a statin. That's the classic. That's the orange line behind me, where it kind of goes up, stays up for a while, and then will come right back down. And that's okay. In this chart here, where that AST-ALT is kind of sitting is around 70 or 80. As long as it's less than 3 times the upper limit of normal for your AST-ALT range, you can watch it. You can wait and see what happens. And they're not having any other symptoms from it. And so you don't want to stop the statin is the main idea. If they have fatty liver disease or if they have a reason to be on a statin, keep them on the statin. That's going to actually keep them alive longer. Don't worry about their liver if it's only a mild bump. And then the other pattern, which is somewhat frustrating, is the pattern where it goes up and it stays up and it never comes down, and you follow it. And then the patient and the primary care doctor get frustrated because I say, yeah, it's probably the medicine, it's staying stable, and we end up doing a liver biopsy in this patient to see what's going on. And the liver biopsy is usually normal, and we say, it's fine, leave it alone, stay on the drug. So as long as it goes up and doesn't get higher than that 3 upper limit of normal, you can do a liver biopsy if you want to kind of convince yourself that the patient's going to be okay and there's no actual liver injury. That's okay. And those are drugs you can continue. What are the unsafe patterns? So if it goes up and it keeps climbing and goes up high, up above the up higher than 3 times the upper limit of normal, that's dangerous. You want to stop the drug. And so that first example with the blue, it's going up to above 300. Stop that drug. It's not worth it. The next example is where it goes up above 3 limit of normal and then kind of plateaus. Well, it's hanging out above that 3 times the upper limit of normal. Still not a good idea to continue it. Stop that drug. And then the last example is the patient with jaundice. So it doesn't matter if they get jaundice, and it doesn't matter how high the AST ALT is, stop that drug, because there's a 10% risk of liver failure if you continue that drug. So that's a big deal. So if they get jaundice, that's a dangerous situation. You want to stop it. Where do I figure out, like, is this drug possibly causing this or not? There's a great resource. It's done by the NIH. If you just Google hepatotox or liver tox, you'll find this website. Any drug you can think of is in there. You pop it in, it'll tell you what are the most common reactions with that drug. It'll give you a couple case examples of real life patients where, you know, patient A was exposed to this drug, and then it shows you their labs, and it's a very nice summary. This was actually down for the past month because of the government shutdown, and so it hasn't been available. I haven't checked to see if it's up again tonight, but now that the government's back open, maybe you guys can use it on Monday. I found it very useful because it's really quick, easy to access. You get an idea, because everyone knows, certain drugs like statins and amiodarone can cause liver failure or patterns, but some obscure drugs I always look up, and just to make sure that what I'm seeing and I don't find anything else wrong, could this be from this drug? So it's a very useful reference. So that's it. To kind of summarize my talk, many patients with chronic liver disease can have normal or barely elevated AST and ALT. So you don't want to rely solely on the AST and ALT to diagnose chronic liver disease. So you want to look at your platelets, your creatinine, your alk phos, your total bilirubin, and your INR to get a generalized summary of how that patient's liver is doing. The trick with the AST being higher than the ALT kind of indicates that this patient may be cirrhotic. Same thing with the platelets being less than 125. Any unexplained elevation in alk phos, especially, the GGT is high 2, you've imaged the patient, there's no sign of an actual obstruction in the bile duct, start worrying about, could they have some kind of hidden infiltrative disease? Do they have some kind of malignancy there, or something less, worrisome like sarcoid or amyloidosis or a TB infection? Those are the things you should be thinking about if the imaging is normal with those elevated alk phoses. Prolonged INR does not mean that the patient's an easy bleeder. That's just one thing that we can look at, and so you can't, treat based on what the INR is. Elevated creatinine is always a bad sign in someone who has cirrhosis, so get them some help, get them to somebody that can take over. And then any drug-induced liver injury pattern that's greater than 3 times the upper limit of normal is worrisome. You want to stop the drug. If it's less than that, it's okay to continue and kind of watch it. That's it. Any questions?